Associate Professor Ann Turner is from the University of Washington's School of Public Health, with a joint appointment in the Department of Biomedical Informatics and Medical Education in the School of Medicine. Dr. Turner's background includes clinical medicine, informatics, and public health. Dr. Turner is also the principal investigator for 2 US federally funded Independent Investigator Awards, one of which is Transform, a 5-year funded project investigating the use of machine translation technology to improve access to multilingual health promotion materials. I would now like to welcome Dr. Turner.
Thank you. Thank you very much. Welcome from Seattle. Hello, friends of multicultural health information. I'm delighted to be joining you for this very important conference. I'm going to share with you the research I've been doing over the last 4 years, addressing language disparities, looking at the use of machine translation to improve access to multilingual health materials. So, for this crowd, this is not new news, but there are a large number of individuals, both in the U.S. and in Australia, that speak a language other than English. And this is of important health consequence because it's been shown that individuals with limited English proficiency have less access to health care, less access to preventive services, and poorer health outcomes than their English-speaking counterparts. And there is, in addition to other avenues, there is a tremendous need for multilingual health materials, and yet this need is largely unmet due to the time and costs associated with producing quality translations. For this reason, we proposed to the National Library of Medicine to investigate the use of machine translation for public health information. And as I said, we're in our 4th of 5 years of investigation. Statistical machine translation is translation that occurs by training a computer with vast amounts of previously translated text. So essentially, you're training the computer so that when new text comes, it can predict what the translation should be. It's for those of you that have used Google Translate or Bing Translate, you know that this technology is not perfect. However, it is getting better all the time. So I encourage you, if you haven't, if you used it 5 years ago and totally got turned off to it, it's worth looking at again. Even when we started this project, we translated, this was from an environmental health document, and this is a sentence that we translated into Spanish. And for the following studies, this has all been done in Spanish because Spanish is the second most commonly spoken language in the U.S. So we took this sentence: clean, unwashable wallpaper with commercial putty-like wallpaper cleaner. Machine translated it and then back translated it, and the back translation was Depp's background of desk of cleaning washable with putty, a commercial cleaner screener background. Makes absolutely no sense. 4 years later, we took that same sentence with the same translation tool, in this case Microsoft Translator, and back translated it, and the current version is clean, non-washable wallpaper with putty-like cleaner commercial wallpaper. So again, it's not perfect, but at least it makes sense, and I think it indicates the improvement in these tools. How Bing Translate and Google Translate work is they go out and find instances on the internet. So for those domains that are best represented on the internet in terms of translations, the translations are better. For those topics that are more specialized, public health, medicine, they generally don't do as well. The types of errors that you see with machine translation include things like missing terms, word order errors, wrong word sense, and morphological errors where the form of the word is a mismatch with the rest of the sentence. What we wanted to know, one of our concerns was if you use machine translation, are there so many errors that actually it becomes so bothersome to translate, to change it, to post-edit it, that it's not worth doing. So one of the first things we did is we did used Mechanical Turk to do a crowdsourcing study looking at what the most annoying errors were with machine translation. And again, this is with Spanish. And the morphological errors were found to be the ones that people found most annoying in terms of trying to correct, followed by missing terms and word sense errors. So it's the morphological errors and the missing terms and the word sense errors that our computational linguists are really concentrating on trying to improve in terms of automated technology. An area of interest of mine is really how to integrate technologies into the workplace, in particular into public health practice. And to do this, we did in-depth interviews with people involved in translation and health departments across the state. We asked people about what tasks they perform, what kind of work processes, how we tracked how long it took to translate, as well as the cost associated with translation. So in these, we did in-depth interviews with 41 individuals from 5 health departments, and we analyzed transcripts and identified themes. In particular, we looked for barriers and facilitators to translations. We also wanted to know what people's goals and values were, and we sought feedback or input on people's attitudes towards machine translation. What we found is, in general, there were various processes in place or different ways that even with different departments within one health department where how things were being translated. However, in general, there were 4 phases that people described. One was a pre-translation phase where an English document was prepared for translation. It may be changing the reading level or taking out idioms or slang or putting in specific sentences that to reach that particular community, the audience community. Then the translation phase, and this often took place in the health department if bilingual resources were available, or if not, they were sent out to commercial vendors. And what we heard over and over again was the most important phase was really the quality assurance phase. That whether it was done in-house or done by, the translation was done by a vendor, there needed to be a quality assurance phase where someone that was representative or very familiar with the audience community looked over the translation to assure that it was accurate. And then the post-translation phase, which really consisted of dissemination of the translation. The main barriers to translation, to manual translation that we found were, number 1 was cost. Some health departments had a budget of $50 for translation, which really doesn't even translate a one-page document. Having trained staff and bilingual staff was or having insufficient staff that were bilingual was a barrier to translation. The competing services and projects that health departments have under limited resources, those were constraints in terms of manually translating. And if there was a general lack of awareness or lack of leadership, that when things were translated, that they, you had used your funds, and there isn't really a culture of sharing documents or organizing archives for these documents. For the cost of translation, and we covered about 30 documents that were translated. The average time for translation, manual translation, was 17 hours to 6 days, with a cost of $130 to $1,200 US, which is approximately $150 to $1,400 Australian. So it's quite costly. In terms of attitude towards machine translation, there was actually quite a variety, a wide range of attitudes, but in general there were concerns about errors in quality. Given the messages that we have in health, we really there isn't much leeway in terms of misinterpretation or mistakes made. So concerns about quality were probably foremost in what people mentioned. Smaller health departments, however, that had fewer resources, in general, they felt more favorable towards translations, using machine translation. And in fact, many of the bilingual staff that were doing translations were using Google Translate or Bing Translate for an initial pass. And then there were also concerns about people who made their living by doing translations, concerns about their job security and what this kind of technology would mean in terms of their future. We looked at the second year of this study, we did post-editing studies. So what we did is we took documents that had been translated from English to Spanish manually. We took those same documents and put them through Microsoft Translator. And then we had public health professionals that were bilingual post-edit the machine translation. And we timed how long it took, and we also gathered information on what kinds of errors they found and information regarding the quality of the translation. Then we took the post-edited, machine-translated documents as well as the manual documents, and we had another set of professional translators tell us, they were blinded to which was which, but tell us which one they preferred. So we took 30 documents. We took the machine translation and had bilingual staff post-edit those documents. And then we had people, another set of professionals tell us which of the translations they preferred. And we were surprised just at how even the results were. For 10 of the translations, the manual translation was selected. For 10, the machine translation plus post-editing was selected, and for 10, it was deemed essentially equivalent. This said to us that if you post-edit machine translation, you really can have an equivalent quality result. In terms of the time it took to post-edit the machine translation took 3 minutes to an hour, and the costs were generally less than $30 for the translation. And again, the quality seemed to be equivalent. So we were convinced by these results that machine translation plus post-editing can save time and costs, and at the same time maintain quality. So the next question is, how does this get integrated into public health practice? If you need post-editing by trained translators, how can we develop a system whereby the resources of the state are are harnessed in order to do this post-editing, because any given health department in our state may have one or two languages represented, but certainly not the whole set of bilingual needs for the community. So we're looking at collaborative translation tools based on the web. We developed a tool whereby a health department can upload an English document, say the languages that they want it translated in. It gets translated using machine translation, and then potential post-editors with expertise in that language across the state get notified that there's a document needed for post-editing. We have just started doing usability testing with this tool, and we will see how well it works. There's issues related to labor unions, and again, this idea of kind of working together and sharing as a whole has not really been the culture with independent health departments. So we have our work cut out for us, but we are hoping to expand this research in the next few years. So just in conclusion, there is a tremendous need for language-appropriate health materials. However, the cost, time, and expertise serve as barriers to producing the materials that are needed. Machine translation using public health post-editors can produce translated materials that are of equivalent quality in less time and therefore less cost. And we think that a collaborative approach to post-editing could provide a way to implement a machine translation system. Our next steps, we're currently looking at a character language. We're looking at traditional Chinese. I can tell you, just based on our preliminary results, it's much more difficult to post-edit. But more will be revealed on that. We also are testing our collaborative tool with a small number of health departments, and we've written grants to expand the dissemination in the state to test it further. I like to acknowledge my co-PI, Katrin Kirchhoff, who's a computational linguist in the Department of Electrical Engineering. Also, Christine Du and Magumu Brownstein, who have been the project coordinators. Many students and volunteers have helped participate in this project, including the staff of health departments, who have really provided us with a lot of valuable feedback. And the National Library of Medicine branch of the NIH, which has funded our research. And here is a list of publications that I drew on in talking about my results, if you would like more details. And again, I want to thank you, and I want to thank Nydia for stalking me and inviting me to be part of this very important program. If we have some time for questions, but if you think of questions afterwards, this is my contact information, and I would be happy to have a discussion with you, or if you want to collaborate, I'm always open to collaborations. Thank you.